Welcome to the TSDA Prerequisite Curriculum Committee presentation on cardiac physiology. My name is Richard White. This lecture has been put together by myself and Dave Fullerton of Northwestern University. The format of this presentation will cover essentially three areas: electrophysiology, microscopic cardiac physiology, and macroscopic cardiac physiology. From the macroscopic standpoint, we'll look at both organ function and more clinically relevant factors as one would encounter in the intensive care unit. To begin with, we'll cover cardiac electrophysiology, and we'll review the action potential, the concept of automaticity, as well as the electrocardiogram. The action potential, which you see in this slide, is most likely quite familiar to you, although it may have been several years since it's been studied, since you've reviewed it extensively. But essentially, the action potential refers to alterations in transmembrane potentials and is based on altering ionic concentrations and permeabilities, as well as active and passive ion transfer. The action potential is composed of 5 parts. We'll begin at phase 0, which is the phase of rapid depolarization. Remember that at the resting state, the intracellular potassium concentration is much higher than the extracellular potassium concentration. The reverse is true for sodium, such that extracellular sodium is higher than intracellular sodium. During phase 0 depolarization, the sodium channels open and sodium enters the cell along its concentration gradient. The transmembrane potential diminishes, that is, goes to a less negative value, or actually a positive value. During phase 1, there is early repolarization, and this is due to transient efflux of potassium, again along a concentration gradient. During phase 2, which is the plateau phase, calcium influx is balanced by potassium efflux. During the late phase of repolarization, which is phase 3, potassium efflux exceeds the inflow of positively charged ions, and the transmembrane potential returns to its resting state, or phase 4. During phase 4, there is a return of the normal ion gradients, and this is brought about by active ion transfer. Cardiac tissue has the unique ability to initiate its own action potentials, and this is termed automaticity. And you can see from the diagram that the phase 4 resting state is not flat, as it was in the previous diagram, but gradually upsloped. At a certain threshold value, the tissue automatically depolarizes and completes the action potential cycle. You can also see that the action potential, or the automatic action potential, is can be modified by varying ion concentrations, and the illustration here is simply what happens if you decrease the calcium concentration. The same can be done by adding a calcium channel blocker. The SA node has the highest intrinsic rate of automaticity and thereby acts as the typical or standard cardiac pacemaker tissue. Other tissues, however, have the ability to initiate beats, and when they become or when the SA node decreases or does not fire, or whether these other foci have a higher rate, they can become ectopic foci. The electrocardiogram is obviously familiar to you, but represents the integration of the action potentials across the entire heart. It has several components: the P wave, which represents atrial excitation; the QRS complex, which represents ventricular depolarization or excitation; the T wave represents ventricular repolarization. Atrial repolarization is a very small wave and usually buried within the QRS complex. The PR interval represents the time it takes for the wave of depolarization across the atria and the AV node, and primarily represents the slow conduction through the AV node. Moving on to excitation-contraction coupling. Then this again should be reviewed. The sarcomere is the basic contractile unit and is composed of overlapping actin and myosin filaments. The myosin filaments are composed of multiple myosin molecules, each of which has a head and a tail. The tail binds actin, and the head has ATPase activity and is the area responsible for oxygen utilization or energy utilization. The actin filament is composed of a spirally wound actin filament and a tropomyosin molecule, or an actin molecule and tropomyosin molecule with a troponin molecule which is interspersed across this filament and is involved in regulation of excitation contraction coupling. The physiology of excitation contraction coupling essentially involves depolarization of the muscle cell. As the action potential crosses the muscle cell, it initiates the release of calcium from the sarcoplasmic reticulum into the cytosol. The calcium causes actin and myosin filaments to slide together. The calcium is then rapidly pumped back into the sarcoplasmic reticulum in preparation for the next action potential. Moving from a subcellular level to an organ level, this slide shows the relationship between wall tension and ventricular volume or preload. It's the familiar Frank-Starling relationship, and here is demonstrated two curves, one of the length-tension relationship during systole and one during diastole. During diastole, the wall tensions are obviously less than during systole. As the diastolic volume increases, there's a gradual increase in wall tension. Initially, the curve is quite flat, attesting to the highly compliant nature of the ventricle during diastole, but it becomes steeper as the volume increases. During systole, wall tension is obviously much higher, and you can see that the force developed increases as a preload increases. This only occurs up to a point, after which further preloading results in an actual decrease in force generation. This is presumably due to the crosslinks between the actin and myosin filaments, which are maximized at a optimal sarcomere length. When the sarcomere is stretched beyond that, as you would see with increasing preload, the number of crosslinks diminishes, consequently the amount of force developed will decrease. In understanding ventricular energetics and cardiac function, it's important to understand the concept of Laplace's law, which is a mathematical relationship that relates tension to pressure and radius in round vessels. For thin-wall vessels, the relationship is simply that tension equals pressure times radius. The implication is that as the radius increases or the volume increases, the tension on the chamber increases even with a fixed pressure. For thick-walled chambers, the relationship is somewhat different, with tension being equal to pressure times radius but divided by width. The important thing here is to realize that tension can be minimized by having a thicker walled chamber. This slide illustrates the pressure and volume changes during a typical cardiac cycle. Much of it's self-explanatory. However, in short, starting at point A to point C, this is diastolic filling. Initially, or during the earliest phase of diastole, the ventricular pressure actually decreases. However, during the latter two-thirds, there's a gradual rise in diastolic pressure. At point C, which is the beginning of systole, there is a rapid rise in ventricular pressure. Remember that blood is essentially non-compressible, so there's no change or minimal change in volume with a substantial change in pressure. At point D, the aortic valve opens and ventricular ejection begins. Blood is ejected between points D, E, and F, and at point F, the aortic valve closes as the ventricle relaxes. Points F to A represents isovolumic relaxation, and at point A, the mitral valve opens and diastolic filling begins. If you look at the same cardiac cycle, but with respect to energetics, the area under the curve represents the stroke work that the ventricle performs. Remember that work can be expressed as force times distance or pressure times volume. And the area within that cycle represents the or the area under the curve represents the amount of work that the ventricle must do. There's another component to ventricular work, and that is in transferring kinetic energy to the blood, but the majority of ventricular work is pressure volume work. This slide represents the simultaneous pressure tracing of the left atrium, left ventricle, and aorta. The important points include the rapid rise in the ventricular pressure tracing between mitral valve closure and aortic valve opening. During the next phase, the aortic and ventricular pressure tracings are coincident. Following aortic valve closure, which is represented by the dicrotic notch, there is a sudden decrease in left ventricular pressure, while aortic pressure declines much more gradually. During the phase of ventricular filling, there's a gradual rise in ventricular pressure. The lowest curve represents the atrial pressure changes, and you can see that there's a gradual rise in left atrial pressure during ventricular systole. This is atrial diastole, and the atria gradually fill. They also tend to be quite compliant, therefore the rate of pressure rise is quite low. As soon as the mitral valve opens, the atrial pressure decreases and is essentially equal to the ventricular pressure. This slide represents the concept of myocardial contractility. The two curves represent the relationship between stroke work and end diastolic volume under two given experimental conditions. In the control condition, you can see that stroke work increases as end diastolic volume or preload increases. As epinephrine is infused, the amount of the stroke work is substantially increased. You should be aware that this is an experimental model with a fixed afterload. The increased stroke work with administration of epinephrine or other inotropes reflects the increased contractility or increased contractile state of the myocardium. This is a difficult thing to quantitate in the intact animal or patient, as preload, afterload, and contractility all vary. However, the concept of contractility is best described as alterations in the length-tension relationships. The next thing we'll look at briefly is the effect of heart rate on cardiac output. You can see that as heart rate increases, cardiac output increases to a certain point, after which there's a gradual decline in cardiac output. The decline after the most efficient point or maximal point is due to diminished time for ventricular filling. If the ventricle can't fill properly, stroke work or stroke volume declines, thereby cardiac output declines. In the normal adult, the cardiac output is maximized at a rate of approximately 150 to 170 beats per minute. We'll move on now from basic physiology to clinical physiology, and at first we'll talk about, we'll review a number of terms: stroke volume, heart rate, and cardiac output. While cardiac output is a very useful term if one is comparing patients, it's often best to use cardiac index, which is output normalized to body surface area, or cardiac output divided by body surface area. The normal values for cardiac index vary as a function of age. For a 20-year-old adult, normal cardiac index is approximately 3.5 liters per minute per meter squared. On the other hand, for an 80-year-old adult, the normal cardiac index is on the order of 2 to 2.5 liters per minute per meter squared. Next, we'll look at the concept of oxygen delivery and oxygen consumption. This slide shows that oxygen delivery can be mathematically expressed as cardiac output times oxygen concentration in the blood. the oxygen concentration in the blood is equal to the hemoglobin concentration times 1.36 times the percent saturation. There's a small amount of oxygen that's actually dissolved in the blood, but the majority is bound to hemoglobin. You should note that there is a linear relationship between oxygen delivery or oxygen concentration and oxygen saturation, and a nonlinear relationship between oxygen concentration and PO2. To measure oxygen consumption, one has to know the difference in oxygen concentrations between the artery and the mixed venous oxygen concentration. The Fick principle relates these mathematically, and as you can see, O2 consumption is equal to cardiac output times the AVO2 difference. In the normal clinical situation, arterial oxygen saturation is near 100%, and the normal mixed venous oxygen saturation is approximately 75%. You can rearrange these terms mathematically to come up with an extraction ratio, which is the amount of the delivered oxygen that is utilized by the tissues. And I won't go through the algebra here, but the extraction ratio is equal to 1 minus the mixed venous saturation divided by the arterial saturation. Consequently, if the surgeon knows the arterial and mixed venous saturations, it's quite simple to calculate the extraction ratio. You don't need to know cardiac output, hemoglobin, or PO2, but you do need to have a pulse oximeter and a Swan-Ganz catheter in place. The normal extraction ratio is approximately 25%. That is a normal arterial saturation of 100% and a normal mixed venous saturation of 75%. An extraction ratio of 40% is distinctly abnormal, while an extraction ratio of 50% indicates a severe insufficiency in oxygen supply. Sometimes it's easier to look at or look simply at the AVO2 differences rather than calculate the extraction ratio, as they generally go hand in hand. An exception to this is in the patient with anemia, who may have a substantially higher extraction ratio but a normal AVO2 difference. The whole point of the preceding discussion was to evaluate oxygen delivery and oxygen consumption, and if one comes to the conclusion that oxygen delivery is inadequate, you have to ask, why is this the case? Well, the options include impaired cardiac output, impaired hemoglobin concentration or anemia, and impaired oxygen concentration or hypoxemia. Well, the purpose of this discussion is to review cardiac physiology, not respiratory physiology, so we'll limit the following discussion to evaluation of impaired cardiac output. There are a number of potential causes for impaired cardiac output, one of which is hypovolemia, another of which is excessive afterload. There can be an intrinsic problem with the heart as a pump. The heart rate may be inadequate, or there may be an abnormal heart rhythm. The normal heart rate is age-related, and in the adult is approximately 60 to 100 beats per minute. In a child, it's higher, and in an infant, it's even higher. If one is determined that heart rate's inadequate, there are a number of things that can be done to improve the heart rate. One can give atropine, which is a vasolytic agent. Chronotropic agents such as isoproterenol can be administered, or in the post-op cardiac surgery setting, it's often easy to pace the patient. It's important to make sure the patient's in an optimal cardiac rhythm, and normal sinus rhythm is generally best. Patients often, after heart or lung surgery, patients often go into atrial fibrillation. In this case, they lose the atrial contraction, a component to ventricular filling, and this can decrease stroke volume by up to 25%. If one is to optimize cardiac output, one needs to optimize diastolic filling. Recall the Frank Starling principle that shows that stroke volume increases as end diastolic volume increases. Therefore, one can simply administer fluid to increase the cardiac output. In order to best or determine what is the optimal filling pressure, it's important to have a Swan-Ganz catheter in place. The pulmonary capillary wedge pressure is generally very reflective of left atrial pressure and consequently left ventricular and diastolic pressure. Filling pressures or left ventricular filling pressure can be approximated by both the pulmonary artery diastolic pressure and the central venous pressure, but these are not as accurate as measuring wedge pressure directly. Wedge pressure over 20 millimeters of mercury is often associated with the development of pulmonary edema, and one should take caution not to administer fluid when the wedge pressure is this high. Once one has optimized rate, rhythm, and preload, next you have to look at the afterload, which is the resistance to blood flow. Another way of phrasing this is to use the term systemic vascular resistance, which can be calculated if you know the cardiac output, mean arterial pressure, and CVP. The SVR is in units of dyne seconds per centimeter to the fifth, and the normal SVR is approximately 1,000 dyne seconds per centimeter to the fifth. Hemorrhagic shock is often associated with elevations in systemic vascular resistance as the body attempts to maintain a mean arterial pressure. In cases of septic shock, the reverse is true, and there's often profound vasodilatation. It's not always easy to measure mean arterial pressure. One has to have an arterial catheter in place, but it's quite easy to approximate mean arterial pressure, and these are two ways to do it. The first being taking 2/3 of diastolic pressure and adding 1/3 of systolic. Another and perhaps easier way to do it is to take the diastolic and add 1/3 of the pulse pressure. Now, the last thing that one can modify is the cardiac contractility, and if cardiac output is still low after adjusting for preload, rate, rhythm, and afterload, it may be necessary to improve contractility. This is often done by infusing an inotropic agent, such as dopamine, dobutamine, isoproterenol, epinephrine, amrinone, or milrinone. These last two slides will go through these commonly used inotropes and their respective doses. Dopamine is often a first-line inotrope and can be used at low doses, which primarily involves the dopaminergic receptors in the kidney. This increases the glomerular filtration rate. As one increases the doses to 5 to 10 or greater than 10 micrograms per kilogram per minute, the beta and alpha adrenergic receptors are activated. Dobutamine is predominantly a beta agent and is used at doses of 5 to 10 micrograms per kilogram per minute. Isoproterenol is used primarily in the setting of heart transplantation. It's a very strong chronotropic agent as well as a beta adrenergic agonist. Epinephrine has both beta and alpha effects and is a very potent inotrope. Amrinone and milrinone are the two phosphodiesterase inhibitors. Milrinone is more commonly used now than amrinone. Both of these agents have fairly long half-lives and act as both inotropes and vasodilators. Amrinone has a common side effect of thrombocytopenia, which is less common with milrinone. Both of these agents improve diastolic relaxation. In summary, an understanding of cardiac electrophysiology, the cardiac cycle, and pressure-volume relationships are essential if one is to understand the complex physiology of the intact human circulatory system. Thank you very much.